here, Professor. And also we have Dr. Hisham bin Sumait and Dr. Mohammed Alakbary. Supposed to have also Dr. Rabea Barabbaa, Dr. Abdulraheem bin Gadhi, and also Dr. Sami Bamadhaj, and Dr. Saeed Noman. We have online Dr. Ahmed Albarida from Sana'a. We have Dr. Khaled Bamakhrama from Dubai. We have Dr. Waheeb Alqobati from Sana'a. We have Dr. Fawaz Amran from the Mar University. Also, we have Dr. Samir Fotih from Al-Madinah Al-Munawwara. We have Dr. Walid Bahaj from Mecca. We have Dr. Faisal Hajri from Ib. We have Dr. Amin Qasim from Ta'az. We have Dr. Ja'am Shabahi from Jeddah, Mecca. We have Dr. Abdullah Al-Humiqani from Canada. Also, we have Dr. Abdullah Basheeh from Riyadh. We have Dr. Khaled Tahar from Canada. We have Dr. Dhiyauddin Abdulaziz from Jizan. We have Dr. Muhammad Amin from Jizan. We have Dr. Abdullah Raqqas from Sana'a. And we have Dr. Muhammad Nasser Al-Bihani from Cairo. Okay, now I'll give the mic to Prof. Fahmi to start the session.
Bismillah ar-Rahman ar-Rahim. We will start the session with the presentation of Dr. Ahmed Madib. Dr. Ahmed is the Professor of Medicine and Medical Oncology, Hadhramout University. He's the founder and former of the director of the National Oncology Center, Hadhramout, and founder and head of Medical Oncology in Saudi Arabia. تفضل.
بس هذه لو تروح. طيب بسم الله الرحمن الرحيم. الله يحفظك. طيب بسم الله. اوكي. هذه ممكن نشيلها نشيلها. طيب بسم الله الرحمن الرحيم. My talk will tackle the precision oncology, which is the agenda of my talk. I will try to define the precision oncology, then I will give some practical examples, and I will conclude my talk by take-home message. So what is the precision oncology? In Arabic, it is طب الأورام المتفرد أو الدقيق. يعني we have to individualize the treatment for every patient. So it is the application of patient-specific profiles, incorporating genetic and clinical data to tailor disease management and preventive strategies. So the other names for this branch, or oncology field, is the personalized oncology or personalized genomics or genomic oncology. So what happened what we have before the era of precision oncology? Before, we were using chemotherapy for all, and we end up with a lot of toxicities, and we don't know the benefit, uncertain benefit, and the treatment was limited to fit patients. So usually we exclude unfit patient, while when we move it to the personalized or precision oncology, we move it from the chemotherapy for all to targeted therapy. So we select and we target one specific mutation that and not only the targeted therapy, but then we move it to the revolution of the immune therapy. So now our treatment based on the biomarkers and specific target that can be very selective with the least toxicity and the highest benefit. So we'll give some examples. Now we'll start with colorectal cancer. Colorectal cancer, no more one disease. One size does not fit all. So I think most of you heard about the story of the 12 patient with non-metastatic rectal adenocarcinoma. This was in the media, and I think most of you, they watched the video in the Facebook and everywhere. 12 patients with rectal adenocarcinoma, with rectal cancer, they were treated in certain way, and this was also the most important event in the last meeting of American Society of Oncology meeting 2022. Why? Because cancer disappeared in all patients without chemotherapy, without surgery, without radiotherapy. So there is new revolution in medicine. We can't treat cancer without rectal cancer without surgery. It was a really very sad year for the surgeons. The fellowship program in the surgical oncology collapsed in the States after this news. Many fellows, they were planning to rejoin the surgical oncology field. They almost disappeared, no show. They did disappear from the field because no more surgery for rectal cancer in such group of patients. So it was groundbreaking study for colorectal cancer that with this drug, we treated cancer without surgery, without chemotherapy, without radiotherapy. And this is the design of the trial. So what they give them, they choose in all patients non-metastatic, stage 2, stage 3, with some mutation. And this is called MSI, high microsatellite instability. They give him a drug called dostarlimab. They give them 9 cycles. After 3 months, they did imaging, and they follow the patient. Those patients who the cancer with complete resolution of cancer or complete response, they did not do anything for them, just watchful waiting, no non-operative approach. They follow them without any further treatment. While the others who have some residual disease, they enter them in the classical behavior. They give them chemoradiotherapy, and they follow them. If they have residual disease, they send them to the surgeon. This is the plan, to send them to the surgeon. And if there is complete response, again, they just follow up this patient cohort. So what happened? All the patients did not need any surgery, did not need any radiotherapy, did not need any chemotherapy. 100% of the patient complete clinical response. So it was this, and they confirmed that by 3 modalities of treatment, of follow-up. They did colonoscopy, look to the colonoscopy. This is the fungating tumor before the start. Look after immune therapy, no more tumor, healthy mucosa. They did for them rectal MRI, the tumor disappeared completely. They supported this issue also by doing PET-CT scan, no more activity. Looked at the tumor, disappeared. So they used 3 modalities of confirmation that the patient responded completely to the immune therapy. With immune therapy means the patient come 30-minute injection, no test, no post test, and he go home without any side effect. Yani very negligible. For myself, I am repeating, around 100 patients, nobody of them they admitted for any side effect from immune therapy. 30 minutes. And discharge. Usually we keep this patient afternoon, after chemotherapy cases. We ask them to come 30 minutes to receive their treatment and to go home. So this is practice change. So 100% clinical complete response for the first 14 patients, and no grade 3 or 4 adverse events, and no patient have required chemo, no patient have required radiotherapy or surgery. And they followed the patient for 6 months. Then now when we have more than 1 year, no patient develop any recurrence. But again, they said longer follow-up is needed. Now, this is now the start. Only 12 patients we have. Now longer study, a larger study is now recruiting patients in this regard. Now, can we treat cancer without surgery? This is another answer came from the OPRA trial. So we non-operative management of rectal cancer patient is there is chance for it, and we know that the philosophy of which watch and wait philosophy and avoiding surgery is it is things that people like it. Now So we'll maintain the sphincter, we'll maintain the function of the patient. And what they found from the previous data which we have, that we can achieve local control and equivalent survival without surgery. So now the watchful waiting is organ preservation strategy for selected patient that who experience complete clinical response. We mean by complete clinical response that the patient has no clinically detectable macroscopic disease. So this is the trial. What this trial, what they did, they gave the patient in this trial, this is not chemo-free protocol. Now they adopted total neoadjuvant treatment. Total neoadjuvant, that means any rectal cancer patient, they are giving them either chemotherapy, then chemoradiotherapy, then chemotherapy, then evaluation. And the aim of this study just to know two things. First of all, to test their initial aim when they started this trial, they want to see what is the best option, to start chemoradiotherapy for rectal cancer, or to start chemotherapy, then consolidate with chemoradio. But during this trial, they discovered that many of the patients, 50% of the patients who received no surgery, they developed complete clinical response or near complete clinical response. So what they did, they adopted the watchful waiting, and they found that by this approach, we can almost achieve equivalent survival for the patient who underwent surgery. So this trial is now again recruiting patient. The initial data promising that yes, we can spare many patients who are exposed now for surgery and stoma, and these we can't treat them without surgery, only watchful waiting. So, and we can say that the recurrence rate almost, if it happened, it is 10 to 15%, and in most of the cases is salvageable. So we have to, till now, it is not the standard of care, because the number which we have and the design of the trial, it was just, it was not the primary endpoint for this trial, but larger, and the final data of the OPERA trial will come within 1 year. So I think this will be again practice changing in the surgical oncology, and in general, it is in oncology now. Almost we are moving toward the conservative rather than radical treatment. So moving to the metastatic setting, metastatic colorectal cancer, I have this patient, Yemeni patient, electrician. He came to me from Jazan. He's 35-year-old, presented with bleeding rectum. Colonoscopy, I did for him colonoscopy, it showed tumor, adenocarcinoma, 15 centimeters from anal verge. I did staging, I found that his lung full of cancer. It is almost, he's 24-year-old. He refused to go to the doctor for rectal examination for personal causes. Then it is catastrophe. Look to his liver. It is no more liver. It is full of cancer, lung full of cancer. So how to treat this patient? Now we are talking about personalized and precision oncology. We are individualizing the basic case by case. We don't give the treatment for all the patients the same. So based on patient characteristic, that means we have to consider the comorbidities, the age, the prior treatment. We'll see performance status, very functional status, very important. Also the tumor characteristics. So tumor burden, resectable or not resectable in the colorectal cancer, we divide the patient for even stage 4, for conversion or no conversion. For conversion, that means I treat the patient with systemic therapy, and then I send the patient to remove metastatectomy for whatever the patient have. Lung mets, liver mets, we go behind. So from the tumor board, we decide from day one, tailor-made approach for every patient. Either the patient from the start will not be resectable, so we consider palliative intent. The other group of patients for conversion. So this patient, so tumor characteristic and molecular characteristic. So we cannot treat cancer anymore without doing molecular testing. So we are doing a long list of, molecular, because we have to choose the, again, precision oncology directed therapy. And also we have to respect the patient preferences. he's accepting the toxicity or not, what the patient wants. So these are the lists that should be done everywhere. By the way, for our colleagues here, that we don't do it, I mean, by the government. This investigation done for free from the drug companies as social accountability. It is free of charge. The government don't pay 1 real for this investigation. It is partnership. We established partnership with all over the country with the drug companies, and they're doing the test they send out or do in-house. They are providing even machines for PCR to do these tests. In our setting, we have it in-house test. So we do it. For all colorectal cancer, we have to do mismatch repair gene testing, microsatellite instability, because of that story which we told before. And for metastatic setting, we have to do some test, microsatellite instability, RAS, BRAF, HER2/neu, and NTRK mutation. These things should be done. And the most important that we have to know that right colon cancer, completely different disease from the left colon cancer. Right colon cancer, it is catastrophic by all means. And it is very refractory if metastatic, very refractory, because most of the cases, they are mucinous and they are chemorefractory, and we end up with catastrophe if it is right side colon cancer. Before in the medical college, because the surgeons teaching us or taught us that because it is late presentation, the right side, and usually the patient, no obstruction, so the right side is bad prognosis. Now it is not only because the late presentation, but also the biology of disease itself. It is completely different from the other side. So back to our patient. This patient came as MSI high. So when the patient, we tested him, it came, he has some sort of microsatellite instability. So if he has microsatellite instability, he's lucky patient, lucky, because he can be treated with chemo-free protocol. So we have 15% of the colorectal cancer, they are MSI and stable. And 3 to 5% of them, they are Lynch syndrome. I think all of us are familiar from the medical college second year about Lynch syndrome. And usually suggested this syndrome by the laws of one of the proteins. We have some proteins, and usually if we have MSI and stable or high, this is a predictive marker of response to checkpoint inhibitors, and we mean by checkpoint inhibitors the immune therapy. So the lucky patient, those patients in the metastatic setting who have microsatellite instability. And what we mean by microsatellite instability, it is some sort of defect in the mismatch repair gene and the nucleotide matching. If we have mismatch repair gene, they can repair the nucleotide mismatch. If there is defect in the mismatch repair gene, we end up with microsatellite instability down. Look to the DNA sequence, the double strand DNA, how stable in the upper line and how unstable and mismatched. This is simply the idea behind this theory. So, yeah.
2 minutes more.
Wow.
2 minutes.
Okay. Now, so we can adopt chemo-free systemic therapy in metastatic cancer. And this is the scientific background. We have this trial. It showed excellent response to use, look, the chemotherapy here, while the immune therapy here. So how superior the immune therapy and progression-free survival, chemo-free, we don't treat with chemo. Now, not only equal, but it is superior. When you choose the immune therapy, it is superior. And the response rate is higher, and the depth of the response is there. So, and the most important thing, the immune therapy, the durability of the response. When the patient responds to the immune therapy, chemotherapy, after 3 months, the patient relapse. Immune therapy, 3-4 years. If succeeded and responded, it will stay well controlled. This is the point. So this is the conclusion of the first part. And we have newcomers. It is not the one drug. We have long list of immunotherapy coming. And can we avoid adjuvant chemotherapy in cancer patients? This is the role of liquid biopsy. We are doing it in most of the hospitals now. I think it is coming soon here, if in our country, if there is partnership with drug companies, because this will minimize the cost. Many patients, they don't need chemotherapy after surgery. And what they do? They check the circulating tumor cells. So we take just liquid biopsy, blood sample, and see if the patient has negative after in stage 1 to 3 colorectal cancer, no circulating tumor cells, no need to give him chemotherapy, just observation. And what is the evidence? We have Galaxy study, look to the patient, those patients with positive circulating, there is difference when you give chemo or don't give chemo. While those patients who have negative circulating test, no difference, no benefit at all from chemotherapy. Don't give patient chemotherapy which has negative tumor cells in his blood. So we can minimize the cost, and still the data need further evaluation, but they are coming soon. Now, moving to just if you allow me, I will give 2 slides for the ovarian, if you can. Okay. Yeah, this patient, another patient, she's again Yemeni patient from Shabwa. She came to me with ovarian cancer. She came with ovarian with metastasis to the liver. She's good performance. She's around 50 years old. We did for her diagnostic laparoscopy, and the surgeon decided to remove the left ovary for good biopsy and omental and liver biopsy at the same time. She ended up as serous adenocarcinoma of the ovary, and we discussed in the tumor board. They decided that they cannot operate her, so we started her chemotherapy, 3 cycles. Then we operated total abdominal. We did a complete radical surgery, and we ended up with 0 macroscopic disease. And then we go to the personalized oncology in ovary. Her sister died of ovarian cancer. When she diagnosed as ovarian, it was catastrophe, and I mean panic to the family. What we did now, we did BRCA gene testing for her. We found that she is BRCA positive. Her name is there. I forget to cover it. Anyhow, then we did for her also we did genomic testing by BRCA. Then we did somatic gene mutation. It comes to us. Usually the results come within 2 weeks. It came also homologous recombinant deficit. That means she's positive somatic and genomic mutation. So we decided for this patient, that means this patient, she has BRCA gene mutation. We decided to give the patient the PARP inhibitors to tackle this mutation. The patient completed now 2 years of treatment, and she is disease-free. So what I mean that, anyhow, yeah, this is the evidence. Look to the separation of the curve by using of PARP inhibitors in this setting, and the patient completed her follow-up, and she is okay. Lung cancer, just 1 minute if you allow. This patient also again metastatic lung cancer. Now, lung cancer means metastatic before it means end of life. It is, even many doctors, they said, let him die in peace. So what he came with massive pleural effusion, and this is his PET-CT scan, massive pleural effusion. We did for him testing, and then we went to the precision oncology. We have now many genes, many mutations that we tackle, and we found. Chemotherapy. This oral treatment, tyrosine kinase, super to the aggressive chemotherapy. It is usually maintainable. Now, this patient, we did for him testing. It came, this is the result, ALK positive. We congratulated him. ALK positive means you are lucky. So we stopped, we did not start chemotherapy immediately. We started just tablet. Now he is receiving his tablet, enjoying good, he's coming to the clinic. For breast cancer, last case breast cancer, this patient came 3 centimeter breast mass, node negative. And she's hormone positive, HER2 negative, that more hormone positive disease. She has strong family history of breast cancer. So what is the role of, personalized oncology or precision oncology in the breast cancer? We did mutation. She came as BRCA1 positive. BRCA1 positive, that means the patient has a life risk of 50 to 65% to develop breast cancer. Even if we treated the right one, it may come in the other breast. And she has also chance of ovarian cancer reaching up to 65%. So that means we have to make patient counseling from the start before go to surgery. We usually do BRCA. When the patient come to us, breast cancer, we do the same time blood test for BRCA, because the surgery should be planned from the start. We have to make family meeting. So I discussed it with her. Do you agree about prophylactic bilateral mastectomy and prophylactic salpingo-oophorectomy? She should decide. Some patients, they refuse. They have the right. And also, not only this, but also we give, after surgery, we give them drugs, that gene therapy. This is the gene therapy based on that. So this is, I think, the last case that I have. And simply, can we drop, because this may be frequently asked question. We said in the colorectal cancer, yes, we can stop chemo. We can avoid chemo and adjuvant. Yes, we can avoid. Now, can we avoid chemotherapy in breast cancer? Yes, we can avoid an adjuvant setting. Now we are giving all the patient chemo, which is not non-ethical, especially patient infertility. Yesterday, we were talking about oncofertility. Now, many patients, they don't need. Look to the, when we apply the precision oncology, 70% of the patients, they don't need chemotherapy, 70%. We are giving 100% chemotherapy, which is not non-ethical. So I think using precision oncology will change the oncology surface, and the solution. Now we started molecular tumor board. It is not only what we do now. Usually we start the regular tumor board. We meet all together. Then we consult a molecular tumor board, molecular biologists there, just to approve our request. Thereafter, they send to central lab, and the biomarkers result come. Then we meet again to put the final plan. So it is, we have many ongoing efforts to acquire precision oncology data in order to characterize further the tumors. And the products are already in the market. So it is nothing new, and it is applicable also in our setting. Just we have to encourage our policymakers to make partnership, and it may result in great benefit to the patient. And but also broader changes should be also, made for the healthcare and insurance system and Arab countries to be to make the precision oncology part of our daily practice. Thank you very much.
Thank you, Dr. Ahmed. It is very nice without chemotherapy, radiotherapy, and surgery. Very nice. Thank you very much. This is a valuable and thank you very much. This is valuable and updated topic. The next speaker is Dr. Omar Belfaqih. Dr. Omar Belfaqih will be introduced by Dr. Hisham.
Dr. Omar, consultant of gastroenterology, hepatology, and GIT endoscopy, endemic and infection disease, MD.
See, when you are fighting surgeon, what will happen? Thank you. By chance, I have also some slide to avoid surgery, but please don't avoid surgeon. Okay. لأنه بيغطوا علينا، نحن نحتاجهم، هو بيسافر، نحن جالسين هنا. The role of gastroenterology in GIT cancer care. Gastroenterology, GI malignancies with high rate of mortality, with high rate of incidence. This is the 5th common malignancy and 3rd cause of death worldwide. I'll go immediately. More than 95% of gastric cancer are of intestinal gastric cancer. That means there's inflammation, metaplasia, dysplasia, carcinoma sequence. Should break this sequence. And everything in our rule of gastroenterology We have preventive measures, diagnostic measures, and therapeutic measures. Please don't be angry from me. We'll avoid surgery a little bit. The application of GI endoscopy technique and new technology will help us so much, and we'll go a little, because in the beginning we have fiber optic endoscopy. يمكن قبل 30 40 سنه كنا بنعمل منظار. اذكر عملت منظار في صنعاء قبل 20 سنه او 17 سنه بالفايبر اوبتيك. قلت وصلت الدودن وانا ما وصلتش، ما عرفتش اوصل. They use white light endoscopy, which is not sensitive to find the neoplasm. This continuous development of medical technology, it helps us widely. Endoscopy has important role in diagnostic, therapeutic, staging, and it improves diagnosis. Endoscopy is the gold standard for diagnosis of GI cancer. Accurate diagnosis for benign, malignant, it will help by endoscopy. And for example, all we know about esophagus. We have GERD. كلنا عندنا جرود كثيرة على قول الدكتور غالب أو جورد. اوكي كلنا عندنا حموضة، بنشتكي من الحموضة، بنقول للمريض بنعمل منظار، يقول لك ذا زايد جاي ياخذ فلوسي. Long time, and then patient has dysphagia and cancer, unfortunately. And by the guideline, you should take from every 2 centimeters, 1 biopsy. The esophagus is 25 centimeters. That means we'll take 12. If we take from 1 centimeter, we'll take 25, 24 piece or biopsy. It's time consuming. Sometimes the patient, they are old. We will kill the patient on the table by this delay. But if we use the technology, it will help us so much. And this, I think I have mistake. Diagnosis, mistake. No, I had no mistake. Misdiagnosis and misdiagnosis. Misdiagnosis, always we have misdiagnosis because we are using in our hospital here second-hand endoscopy, very bad quality of endoscopy, and we couldn't find. Sometimes we have bad preparation, and you say, oh, the patient's good. Sometimes we are in a hurry to make colonoscopy, and then the patient is saved. No, please. Overconfident doctor has many complications and also have misdiagnosis. Misdiagnosis, like this misdiagnosis helped by technology, like AI, artificial intelligence, and misdiagnosis like misunderstanding. Sometimes you find a lesion. Say, oh, this is a lesion, maybe erosion. Please take biopsy because the small erosion, sometimes it is ulcer or it is cancer. And this has happened for me when I was working here before 1 year. There's a man come, 65 years, come with 6 months vomiting. They made CT scan and they say, ah, this is a cancer. I have a friend of mine in the hospital say, please do CT scan. Okay, we'll make operation. She said, no. Omar, please take biopsy. When I enter, I found this, please video, this this video make when we are shocked. We find big amount of resort and have 7 carry bag, and it is not cancer. Sometimes we found a mass, and they say, oh, maybe this cancer, we immediately go for surgery. Maybe it is multiple lymphoma, should be treated as for Helicobacter pylori, and then we send the patient for a surgeon or oncology center. Endoscopic technology, but please don't forget the other modality, ultrasound, CT scan, RCP, MRI, endoscopic ultrasound, and we'll speak about endoscopic ultrasound more. Before they use chromendoscopy, كنا بنستخدم صبغات ميثيلين بلو، اندوكارمين، كريزل فايولوت. ميثيلين بلو نحن الان بنستخدمها في زرع البالون، بنحقنها داخل البالون، لكن this is not helping so much. We'll see this methylene blue. There is not help so much that time, and now there is MBI, narrowband imaging, eye scan, FICE or fundamental intelligence enhancement, magnifying narrowband. This will help so much. As in this case, see, you can by normal endoscopy, there's nothing. Barrett esophagus, but here there's nodule. This is a malignancy. And we avoid surgery by this way. We make EMR and radio frequency ablation. Also, there's the different type of tumor, protruded, elevated, depressed, this anosmical jump. And by the new technology, we can imagine that this is neoplastic or non-neoplastic. This is helping us. Please don't buy old endoscopy because you'll not help your patient. This is the different. We'll see. We'll go quickly to find here. Maybe the histopathist will be angry for me. Sometimes you are making confocal laser endomicroscopy. During the endoscopy session, there's a probe inside the channel, and we can find that this is malignant or not in the same session. Okay, if you have suspicion of cancer, we'll find in this slide. You have the same patient like this. Small lesion. It's by normal endoscopy, white light endoscopy. But when you change to narrow band, sorry. You find that, there's a cancer here. Okay, the technology helping me. Please, video. I should have my computer here, but I don't know.
This is a 72-year-old Japanese
By using
amateur, is
narrow
more than
band,
30
in
millimeters.
the beginning,
The diameter is subject
you
to
see,
gastric lesion
normal.
diagnosed as
But when you change
adenoma
to
by
the
forceps
narrow
biopsy,
band imaging, this is a cancer.
or microcephaly.
And there's another also.
Endoscopic
It's
examination
normal
at another
tissue
hospital,
now.
a
But
slightly
when you change
reddish
to
area
other
was
technology
detected, a
narrow
very
band,
faint
you
lesion
find there's a
was almost
cancer.
indiscernible.
That means the technology helping us. And yesterday we have a tour inside the colon. Today be ready for a tour inside the stomach and hepatobiliary. Will be free of charge. Don't worry. هندفع فلوس جدا. Okay. This is a this band technique for radio for endoscopic mucosal resection, and this is ASD. Video, please. Second video or third video. I'll jump immediately.
Der 46-jährige Patient
This
leidet
parietal
unter
esophagus, and patient has cancer. By endoscopic band technique, we take this tissue, so we'll avoid a little surgeon, okay? Don't be angry, friend. And then after we took this tumor, we use radiofrequency ablation to ablate the residual tissue, and also for parietal esophagus with high grade, we make radiofrequency ablation. This probe will ablate the tissue, will help us.
The whole range of
for-
accessories is shown firm.
like this. Also, I'll jump because we have no time. Another video, please.
Showing you
The
focal
tour, I
device.
promised him was a tour. This is endoscopic submucosal dissection for gastric cancer. There's different way, but I'll go immediately to the cancer. See the tissue inside the stomach. أنا لو عندنا تفاحة معفنة إيش هنعمل؟ هنخرج المكان اللي فيه العفن كذا زي. But we are in need for endoscopic ultrasound to help us to make local regional staging of the tumor. And see this, the tumor will be after resection. It's called submucosal dissection. And the place will be clean. The tumor gone. See, there's no tumor. It's finished now. Please don't sleep. The other video, they are waiting for the tour. This is a capsular endoscopy. Oh, they say we want to do the capsular endoscopy. This is easy, yeah, easy, but expensive. But also, it is also for diagnostic. There's no therapeutic. They are discussing to make this, to take biopsy, to make this maybe in the future. This capsular endoscopy, there's video capsular endoscopy for upper GI and colonic capsular endoscopy. This is a tour for to complete the tour for yesterday. Next, please. No. Anyway, this is ERCP
This
to
is a video
diagnose
of
the patient.
endoscopic
We should
retrograde
take
cholangiopancreatography.
cytology. In
or
our country, we are putting the cytology brush, take it, clean, and then use it for another after sterilization. In other country, they cut the brush to have cytology, good amount of cytology tissue. This is the ERCP helping us to find the many strictures or malignancy like cholangiocarcinoma and take biopsy by cytology brush, helping us
to place a stent in the duct, ampulla of water. Sleep from the ampulla.
This is the way for diagnosis. As now we are
Here, the
diagnosis.
stent is visible on an X-ray.
PowerPoint, yes. Sorry. So capsular endoscopy already used for diagnosis, but not helping for treatment. ERCP is to find major and minor papilla, to find the access to biliary and pancreatic duct. Therapeutic also is helping us. And I'm not go. This is the ERCP and also the picture, nice picture for fluoroscopy to see the biliary tree. And this or is RCP also helping us for diagnosis of the patient. This is stricture, and this is double duct signs for pancreatic cancer. This is different accessories. You use stenting, as I told you, diagnostic, palliative treatment, and curative or therapeutic endoscopy. We'll speak a little. Now, you have ERCP in Yemen and stop. We hope that we can improve our situation. There is cholangioscopy, spyglass, endoscopic ultrasound. This is the spyglass. Inside the ERCP, we'll put another spyglass, give a picture for the strictures. If there is stone, they make lithotripsy and to fragment the stone. Please, video. I'm sorry, you're tired from me.
Insertion of plastic C-guided cholangioscope with double bed.
This is the RCP, and this is cholangioscope. This CBD polyp, CBD common bile duct polyp, and there's gallbladder polyp. Here they are on gallbladder polyp. If it is more than 10 millimeter, cholecystectomy. Now, please don't waste our organ. We are in need for our gallbladder. There is for acute appendicitis. Don't make appendectomy. Tamam? Because we are in need for you. Okay. Because there's appendicitis, we can clean after endoscopic ultrasound the area or to put a stent. The patient has common bile duct polyp. See, they are making polypectomy inside the common bile duct and inside the gallbladder. No need to waste our organ. Maybe after some time, will not all the people have no gallbladder or appendix. But we are in need for you, please. Avoid surgery, not surgeon. This video, this is AI, female AI. Maybe we'll use by mobile to know who will hit you. And this is AI and endoscopy, artificial intelligence. Also, there's artificial intelligence inside the common bile duct to find the polyp. There's highlight will help you to find inside the common bile duct.
Also,
there is cholangioscopy. There is pancreatoscopy. Maybe after 100 years will come. Maybe. But I'm sure within this year, endoscopic ultrasound will come to Hadhramout and the spyglass will come, inshallah. We have virtual colonoscopy here also in Hadhramout.
So this is the process we are going.
See, you found that the lesion and if there's malignant stricture and you can take biopsy.
Strictures and malignant.
Endoscopic ultrasound. It is very important for early cancer staging. It is like endoscope and ultrasound, using both. The ability to see the different layers of the GI, also to see extraluminar tissue and organ, and also it can help for us to take a biopsy for staging It is more specific than other modalities like CT or MRI. It is used for screening, can be used for screening. This is the endoscopic ultrasound. There is two types, a radial and linear. We can see the pancreatic tissue. You can see here this the normal ultrasound, how much the specificity and sensitivity. This is MRCP, magnetic resonance cholangiography, هذا موجود في صنعاء. And this is ultrasound. We give us good for diagnosis and for biopsy. This is the tour now. Please, I want this video. This is a tour inside the stomach to reach the small intestine, second part of duodenum. مش هو. Anyway, this is endoscopic ultrasound with cholangioscope together. This is the endoscopic ultrasound for patient head stricture. The picture this here for cholangioscope, common bile duct picture. We are inside the biliary tree. It's a tour, free of charge, to see your biliary tree, if it is there is a stricture or no. If there is a stricture, will be can prevent the development of cholangiocarcinoma, or at least to know that the patient why has the malignancy, and of you can treat the patient by stenting. Another video. Still, I'm waiting for the tour. This is the tour.
Endoscopic ultrasound is an the lining of the gastro.
This is the endoscopic ultrasound coming from the mouth. As you see, there's a probe. This is the probe for endoscopic ultrasound, and also there is the camera for endoscope. You go to the stomach and you can go to the second part of duodenum. You have to see the different layers from in outside. Ultrasound just from outside, and here you can make staging. We take biopsy, and also for cholecystostomy. Sometimes if there's gallbladder stone, please don't go to do cholecystectomy. Just cholecystostomy, take the stones out and keep gallbladder. Your gallbladder, you are in need for your gallbladder. Avoid surgery, but not surgeon, please. هيزعلوا مني.
Keep this tract open and
Okay.
allow the cyst fluid to drain into the stomach.
Next video also, please.
Pseudocyst dissolve.
I have a lot of videos. This percutaneous, this is as a palliative treatment. Patient has esophageal cancer. He come to us late, but you can do take biopsy, has cancer. How do to make esophageal stenting? Sometimes if the cancer is more than 2 centimeters in the upper 2 centimeters, it's difficult to make stenting. We make gastrostomy for feeding. And this is used in Yemen before maybe 13 years. It take about 7 minutes. Easily, don't do NG tube because make reflux and inflammation and respiratory infection. This is just will take 7 minutes to keep your patient with good nutrition. The scope is going to the stomach and then make incision inside the abdomen to take the gastrostomy tube through the mouth by help of endoscope. And this will be good for feeding. Next. Sorry, I have many videos, but I think it is better to illustrate than to explain. Virtual colonoscopy. Yesterday I couldn't speak about it. Here it is in Hadhramout since maybe January, about 5 or 6 months we are using, but we need for training for technician people. The 3D image to see your colon. And when we are using this, it is not invasive. It is improve the compliance of the patient, because Dr. Ahmed, he say some people, they don't want to make colonoscopy. This can help, but it is not therapeutic. You should go for therapeutic. What indication? Screening for colorectal polyp, failure of colonoscopy if there is anatomical condition or pathological condition, of also to see the extra luminal lesion. Please video. Visual colonoscopy. I didn't know the video. Anyway, summary. And understanding the endoscopic finding is very important, because to have good endoscopists should have big or long time training. And for me, I'm willing to open training center in Hadhramout. And this is my dream. Also, we support through my society. We have Yemeni Study Association for Liver and Biliary and GIT disease to make some training outside Yemen. At last September, we have about 10 doctors to go to Hyderabad for a workshop, but unfortunately to some issues, we have 3 doctors, only me and Dr. Omar Banafa and Dr. Mohammed Al-Mujahid from Taiz, Omar Banafa from Aden, and we want to come to take some doctors from Shabwa, from Abe, from Taiz, from Mahara to have training. Training is very important. This training, they go to Hyderabad. I told them that you will get only free registration, about $900, but they got 3-star hotel free. They got shuttle bus, airdrop, airport, drop up, pick up and drop off. They find also food for free. And I hope next September, if any doctor has master degree or higher in gastroenterology, we can help to support them through our society. And Mukalla, any doctor, you want to have training after establishment, that training for any doctor has master degree in internal medicine or higher, we can train them. We are in need for many doctors, will not live forever. Maybe our families, our relatives, they are in need for in other cities like Tarim, Mukalla, Gatan. I'm willing to help them. So in Yemen, you are in need or to have new endoscopic machines. Unfortunately, Mukalla, Sayun, Mukalla, there is no endoscopic machine here. Imagine Ibn Sina or Shahar in Aden, only in Sadaga, and they have the quality not that much, and they are in need for training. I know my colleague, they are in need because most of the doctor, they are not able to reach Sika. Imagine this, how to find that the patient has cancer in the colon. Some of them, about maybe 30% to say they are in need for training. Maybe about 90%, I need 1 minute. There's maybe about 90% they are not able to reach terminal ileum. So the solution for this, to have university training center, governmental training centers. Thank you.
شكرا دكتور عمر على this nice presentation. Next session. Sorry, next lectures. Speaker Dr. Abdulraheem Qasim. He is a board certificate hematologist and medical consultant at medical oncologist. تفضل من على الزوم نسمع الليكتشرز.
Dr. Abdulraheem Qasim is a board certified hematologist and medical. شوية بس دقيقة 1 minute. A medical oncologist at Advent Health Center in Shawnee, Mission, Kansas, United States of America. He was born and raised at Al-Mahwit, Yemen. He received a high school education at Al-Thawra School in Al-Hudaydah. And he is now working in Missouri, Kansas, in USA. Start.
Qasim, medical oncologist and hematologist in Advent Health Cancer Center in the United States of America. And today I'll be talking about updates in the management of rectal cancer. Mainly, we will spend time talking about neoadjuvant, total neoadjuvant therapy or TNT. The objectives of this talk is mainly to review the new data and treatment of locally advanced rectal cancer and the benefits from the TNT. We will review some of the randomized clinical trials as well as current guidelines, and we'll review some key notes or take-home messages from the talk, inshallah. What's the definition of locally advanced rectal cancer? So based on the MRI criteria, locally advanced rectal cancer are those who can be classified as intermediate risk or high risk. T3AB, low rectal cancer, meaning in the lower third of the rectum, and any findings of in one or higher disease. But also a very important findings in the MRI is any evidence of involvement of the circumferential margin or endomucosal vascular invasion. The standard treatment for rectal cancer has been going on for decades, and that's mainly administering preoperative chemoradiation, followed by surgery, transmucorectal excision, TME, and then chemotherapy. The problem with the standard approach is there is limitations in finishing and giving the adjuvant chemotherapy. As we know that chemoradiation and surgery are local treatment modalities, and the chemotherapy is systemic treatment modalities. In patients who receive suboptimal treatment of the chemotherapy, they will be at much higher risk of systemic relapse or appearance of metastatic disease. So patient who undergo surgery first, and then you try to give them chemotherapy after, usually they run into problems with delays in chemotherapy. And as we know, delaying chemotherapy more than 8 weeks after surgery may have an impact on the outcome. And also the compliance of giving adjuvant chemotherapy after surgery falls down significantly. In some of the NCDB analysis data, up to 68% did not receive adjuvant chemotherapy. And NCCN analysis data showed that 17% did not receive adjuvant chemotherapy. And less than 50% who received adjuvant chemotherapy, they did not finish all planned cycles. So for that reason, the thought came in trying to move the adjuvant chemotherapy up to be given before surgery to improve compliance and see if that will improve the outcome. So the pros of giving TNT or doing chemotherapy before surgery is early treatment of micrometastasis, improved tolerability, better local and systemic control, decrease interval from ileostomy to reversal. And because after surgery, a patient does not need to wait for 4 months to finish the chemotherapy and then do the ileostomy reversal, they can, wait until it is appropriate, and they may need to wait, 6 to 8 weeks, and that's it. Concerns about giving total neoadjuvant therapy is there is always a concern about overtreatment, and that correlates with inaccuracy of the preoperative evaluation, development of resistance and changes in tumor biology after first treatment. And there is concern about compliance to chemoradiation if induction or chemotherapy of consolidation treatment done before surgery, and there is a concern of delaying surgery. There's 2 ways to do the total neoadjuvant therapy. It can be given as what we call induction chemotherapy strategy, in which chemotherapy goes first, and then you give chemo radiation and then TME. We call that induction chemotherapy strategy. Or you start with chemo radiation and then you do chemotherapy after that, and then TME, that called chemotherapy second, or consolidation chemotherapy. There's many trials that looked at the role of chemotherapy first or induction chemotherapy in the TNT strategy. Here's just a short list of most of the most common trials, or the most famous trial that use this strategy. As you can see, most of them are phase 2 or phase 3 trials, and they used similar criteria for definition of locally advanced rectal cancer. All of them started with chemotherapy first, then chemoradiation, and then surgery after that. The chemotherapy regimen varied between those trials. The primary endpoint was similar in most of those, in which downstaging, complete response rate evaluation are the main outcome. We will highlight, the last trial, the Prodige 23 trial. We will highlight it more in our talk today, inshallah. But a common theme between those trials that used chemotherapy first, if you look at the toxicities and complication chart in here, you see most of the patients have better chemotherapy toxicity and chemotherapy compliance. Not that much difference in the chemoradiation toxicity and chemoradiation compliance. And more importantly, there was no surgical complications or no increase in surgical complication in this TNT trials compared to the standard of care. If we look to the efficacy, there is, some of those trials, showed improvement in the pathology complete response, and there was improvement in the disease-free survival and improvement in the distant metastatic risk, and but there was not that much improvement in overall survival or improvement in the rate of R0 resection. Let's highlight this trial called Prodige trial, in which it used induction chemotherapy strategy as a TNT treatment, in which the experimental arm, they used induction chemotherapy with FOLFIRINOX, 3 months of FOLFIRINOX followed by chemoradiation using capecitabine and long course radiation treatment, and then TME, and then 3 months of FOLFOX or capecitabine, and compared to the standard arm of chemoradiation followed by TME and then adjuvant chemotherapy. What is more important about this trial is we see a much better improvement in the pathologic complete response rate of 27% compared to 12% in the standard arm. And that was statistically significant. There was also improvement in the 3-year disease-free survival and metastasis-free survival as well. If we look to the other strategy in which they used chemotherapy seconds, meaning they start with radiation and chemoradiation, and then consolidation chemotherapy, and then surgery. There's many trials that looked at that strategy as well. Most of them, they use the same criteria for locally advanced rectal cancer. Some of them used short course radiation treatment, and some of them used long course radiation treatment, but all of them used radiation concurrent with chemo upfront, and then chemotherapy, and then surgery. If we look across those trials, in terms of toxicities and complications compared to the standard arm, there is Definitely much better chemotherapy compliance using this strategy compared to the standard arm. There is also better tolerance to radiation treatment. So in terms of toxicity, it seems to be better. In terms of effectiveness, there is much higher rate of pathology complete response rate compared to the standard treatment. There is an improvement in disease-free survival showed in some of those trials. And also some trials showed overall survival, but most of the trials did not show that overall survival. I expect probably the time will tell as more events happen with time. We'll highlight the Rapido trial, which used this strategy. The Rapido trial basically used a short course radiation treatment in which 5 days of 5 gray per day, short course radiation treatment, total of 25 gray in 5 days. And then patient received consolidation chemotherapy with K-box or FOLFOX, and then underwent surgical resection when they used that in comparison to the standard arm of radiation treatment, long course radiation treatment with K-box, with capecitabine, and then surgery, and then optional 6 months of adjuvant treatment. And what was shown in those trials is in this trial, basically there is more compliance with the treatment. 67% of patients completed planned cycles of treatment compared to only 47% in the standard arm. And the pathology complete response rate was 28% compared to 14%. There was improvement in the distant metastasis survival as well as disease-related treatment failure. Now, as we saw, all of those trials showed improvement in both pathology complete response rate and showed that this TNT approach is better tolerated. And there is improvement in PFS and distant metastatic disease. So the question was, which one is better, doing chemotherapy first or doing chemotherapy second? Induction chemotherapy or consolidation, and that's what this study looked at. A phase 3 study in which most of patients were clinical T3 or T4, and more than 86% has a lymph node positive disease. The primary endpoint was pathology complete response rate. This study, they, arm A, which was the induction chemotherapy arm, started with chemotherapy and then rest and then chemoradiation. With the chemoradiation, interestingly, they used 5-FU-oxaliplatin and then rest and then surgery. In the chemotherapy second arm or the consolidation arm, they used chemoradiation first, rest, chemotherapy, and then rest and then surgery. So if we look at the efficacy chart in this study, we see most of those are comparable. Most patients completed surgery. R0 resection rate is very similar. Sphincter preserving surgery very similar. But the pathology complete response rate was higher in the consolidation arm than in the induction arm, meaning using radiation first resulted in higher pathology complete response rate. And a lot of people think that was because there's more time between finishing radiation and surgery in the consolidation arm than in the induction arm. Now, another trial that we need to review here is called the OPERA trial, organ preservation trial. In this trial, the investigational arm, they study it in patient with stage 2 or stage 3 rectal cancer. They randomized to either receive chemotherapy TNT or induction chemotherapy TNT, followed by restaging, and based on radiographic, clinical, and biopsy staging evaluation, people who had a complete clinical response, they watch them, and people who does not have clinical response, complete clinical response, they undergo TME. And that was compared to the historic control of preoperative CRT, followed by TME, and then adjuvant chemotherapy. What we learned from this trial is also there was much higher percentage of organ preservation and pathologic complete response or clinical complete response in the consolidation TNT arm than induction TNT arm, and that probably is also related to the differences in the interval between CRT and surgery. The difference was 8 weeks in the induction arm and 12 weeks in the consolidation arm, and that may have contributed to the difference that we see in the rate of complete clinical response. Should every patient be treated with neoadjuvant chemotherapy? Yes, as long as they meet the definition of locally advanced rectal cancer, because there is much better tolerance for the treatment if administered all pre-surgery. There is definitely much higher complete pathologic response rate, much better tolerance, much better disease-free survival, and metastasis-free survival. As of yet, it has not shown improvement in surgical outcome, and it has not shown improvement in overall survival. And finally, let's talk about locally advanced mismatch repair deficient rectal cancer. It represents 5 to 10% of our rectal cancers. It's usually less sensitive to chemotherapy, and it is resistant usually to chemotherapy. And there has been some evidence of disease progression using regular chemotherapy. That's led to looking for different strategies, and because the activity of BDL1 and PD1 inhibitors in metastatic tumors with MSI high tumors. It was studied in people with locally advanced rectal cancer, and this phase 2 trial done in Memorial Sloan Kettering reported in New England Journal of Medicine. They used this BD1 inhibitor, dostarlimab, in the neoadjuvant setting in people with locally advanced MMR rectal cancer for 6 months, and then they based on the response, they decided to either observe people, or if there is no response, proceed with chemoradiation, and then further evaluation of the response and surgery versus observation. And what is interesting about this trial, in the first 14 patients enrolled in this trial, all of them, they did have a complete pathologic response. Just to summarize what we learned from today's lecture, is that the addition of neoadjuvant chemotherapy increased pathologic complete response rate and improved disease-free survival, but overall survival benefit is yet to be proven. Neoadjuvant chemotherapy did not significantly increase post-operative complications or impact surgical outcomes. Consolidation chemotherapy was associated with a higher pathologic complete response rate and may be the preferred TNT approach for organ preservation. Neoadjuvant chemotherapy can be omitted in patients with low risk T3 and 0 disease tumors to avoid over-treatment giving risk of clinical overstaging, especially in patients with tumors in the mid to upper rectum. Thank you very much for listening, and I'll be happy to take any questions.
Thank you very much, Dr. Abdulraheem, for his talk about the update management of the colorectal cancer. The next speaker or the last speaker in this session is Ismail Al-Azzi, Dr. Ismail Al-Azzi, introduced by Dr. Hisham.
Dr. Al-Azzi is a medical oncologist, assistant professor in the University of Toronto, currently cover the GU clinic at Acute Oncology Service of Princess Margaret Cancer Center.
I don't have any financial disclosures. This is my learning objective is to review highlights of the advances in clinical and translational research related to genitourinary cancers, to identify emerging trends and strategies designed to improve the quality of care of the genitourinary cancer, 3, evaluate tools and resources for management of genitourinary cancer that can be used to achieve effective cancer care delivery and improve the patient experience. So there have been significant advances in management of advanced genitourinary malignancy in the last decade, especially in prostate, bladder, and renal cell carcinoma. This is my lecture outline. I will speak about renal cell carcinoma update, urothelial carcinoma, and prostate carcinoma update. We'll speak about adjuvant and metastatic setting. So let's start with renal cell carcinoma. As you know, the standard of care for management of early stage or sometimes locally advanced renal cell carcinoma is nephrectomy. The role of adjuvant treatment after nephrectomy was addressed by many clinical trials before addressing the TKI, tyrosine kinase inhibitors in adjuvant setting, like bazobanib and sotent and sorafenib, and also axitinib. All of these trials failed to show disease-free survival, except for the sotent in STRAC clinical trial, the randomized patient with sotent and placebo or placebo in high-risk population, and this showed disease-free survival. But no overall survival, and there was high toxicity and there's high percentage of patients who discontinue the clinical trial. Until recently, Keynote 564, which is adjuvant immunotherapy versus placebo in clear cell renal cell carcinoma, the randomized patient, high-risk patient to receive after nephrectomy within 12 weeks, either pembrolizumab 200 milligram every 3 weeks or placebo. They give the high-risk patient, this is the definition of high-risk patient, this study, either pathology T2 with grade 4 or sarcomatoid, or T3 with any grade, T4 with any grade, or lymph node positive, or metastatic disease who, for those patients, underwent metastatectomy within a year of nephrectomy. This study showed significant disease-free survival favoring pembrolizumab with hazard ratio 0.63, and this benefit across all risk category with intermediate, high risk, and high risk, and no evidence of disease. Favored the pembrolizumab with significant hazard ratio 0.28 for those patients underwent metastatic the first 1 year. The overall survival, it showed a significant hazard ratio 0.52. So nowadays we give adjuvant pembrolizumab and other immunotherapy that was tested for adjuvant treatment, like atezolizumab and nivolumab, and even combination of nivolumab, ipilimumab, failed to show any disease-free survival or overall survival. Moving to the metastatic update, as we know, we treat patient based on the risk category. So we categorize the patient based on IMDC score, either to good risk or like favorable risk, or intermediate or poor risk, based on the IMDC criteria. And the treatment for the first-line clear cell renal cell carcinoma is based on this recommendation. Either we always encourage clinical trial for all risk category, but the standard of care is to give either pembrolizumab, axitinib, or cabozantinib, nivolumab, or lenvatinib, pembrolizumab as a first line for favorable risk. For intermediate and poor, in addition to the same combination with addition to nivolumab, ipilimumab. And this is based on Checkmate 214 that showed Nivo AB as arm showed a significant overall survival compared to Sutent arm with a significant hazard ratio and p-value in intermediate and poor risk group. Pembrolizumab axitinib showed a significant overall survival also in all risk category and intention to treat. This is a keynote 4-6, and a Checkmate 9E4 first line nivolumab cabozantinib versus Sutent showed a significant survival outcome for those patients on combination arm versus Sutent. And then clear study also first line lenvatinib pembrolizumab showed a significant overall survival for pembrolizumab versus for lenvatinib pembrolizumab combination versus Sutent or risk category. The update in the update in Check9ER, which is a combination of Nivo cabozantinib, showed a significant overall maintained after 3 years overall survival for combination arm 49 months versus 35 months with significant hazard ratio. So it's benefit the benefit around 11.8 months. For the second line, usually we give, if you start with Bembro axitinib, you can switch to cabozantinib as a second line. Third line, lenvatinib, everolimus. If you start with Nivo, you can go with cabozantinib. Some people give Sutent. And then for the third line, cabozantinib, then lenvatinib, everolimus. And we encourage always clinical trial if available. The new update in management as the second third line is tivozanib, which is an oral tyrosine kinase inhibitor that inhibits phosphorylation of VEGF receptor, VEGF receptor 2 and 3, and inhibits c-KIT and belated white growth factor. Based on this clinical trial, TIVO3 phase 3 clinical trial, tivozanib versus sorafenib that showed overall survival after failure of VEGF. Progression-free survival after failure of VEGF and prior immunotherapy, with overall response rate 18% for tivozanib versus 8% for sorafenib. Also, pembrolizumab lenvatinib, based on the keynote 146, showed also for those patients with prior immunotherapy receipt, they can go with pembrolizumab and lenvatinib. And we have now clinical trial at Prestige Market given pembrolizumab lenvatinib as a second or third line based on clinical trial and umbrella clinical trial. Belzutifan is the HIF2 alpha inhibitor, and now it is one of the treatment option after failure of TKI and immunotherapy. Overall, based on this clinical trial with overall survival, overall response rate, 25%, CR 2%, PR 24%, and disease control rate 80%, with progression-free survival in this cohort 14.5 months. And nowadays we give it in combination lenvatinib and pembrolizumab based on clinical trial in Prestige Market as a second and third line. And also we give it adjuvantly with pembrolizumab as a clinical trial in Prestige Market. Prestige Market is one of the sites of multiple sites for those clinical trials. Urothelial carcinoma for refractory superficial non-muscle invasive bladder cancer for those patients recurrent and not responsive to BCG and decline cystectomy. They can go for pembrolizumab every 3 weeks. with a good disease-free survival 24 months, around 34.9%. And the duration, the disease-free survival also for any disease showed also in 36 months, in 24 months, 33%, and in 12 months, 41.7%. Time to invasive for those superficial to go like to transform to invasive or metastatic disease around 46 months, with in 12 months 88.2 will be free from metastasis, which is a good result for recurrent and relapse non-muscle invasive. And this also the overall survival for this cohort not reach. So this is the result of Keynote 057. Now it is pembrolizumab one of the options to treat those patients unresponsive to BCG with non-muscle invasive bladder carcinoma. As we know, for locally advanced bladder cancer, the treatment choice is to give neoadjuvant chemotherapy followed by surgery or triple modality to preserve the bladder. Adjuvant treatment, initially, adjuvant chemotherapy was available for all patients of after bladder, but most of the trial underpowered, and there were many meta-analyses that showed survival benefit. But you know, chemotherapy has side effects. So this clinical trial is addressing immunotherapy, nivolumab, given every 2 weeks after surgery versus placebo. This is a Checkmate 274 phase 3 clinical trial and showed a significant disease-free survival for nivo arm versus placebo. And for BDL1 expression, the survival advantage, the disease-free survival advantage more than those less than one BDL1 expression. And this subset analysis showed the benefit more with bladder carcinoma, not pelvis or urinary pelvis or ureter, and also the benefit more with those BDL1 more than one, and no, and if the patient receive a neoadjuvant chemotherapy, it will be better survival outcome. This is a follow-up disease-free survival after 36 months for the same trial, showed a 22 disease-free survival versus 10 with hazard ratio 0.7, and BDL1 more than 1% was significant. Those patients had BDL1 has significant disease-free survival 52.6 versus 8.4 months. Other adjuvant clinical trial, immunotherapy clinical trial, atezolizumab and pembrolizumab. Atezolizumab failed to show disease-free survival, overall survival, and this they're waiting for the results of pembrolizumab. For metastatic urothelial carcinoma, as we know, baseline treatment is a combination of cisplatin-based chemotherapy with overall response rate 45 to 50%. Sometimes patients have a renal impairment, so we give them a carboplatin-based chemotherapy and the response rate of 40%. If the patient has BDL1 and is ineligible for cisplatin, he can go for immunotherapy first line with the overall response rate around 15 to 20%. Those patients achieve a disease like a stable disease or partial response, they can go for maintenance avelumab, overall survival 21.4, or second line immunotherapy. Now, if the patient has FGFR positive, he can go for second line erdafitinib, which is anti-FGFR, or to go for enfortumab vedotin, which is the antibody drug conjugate, or sacituzumab antibody drug conjugate. Many attempt before to combine immunotherapy to chemotherapy as a first line based on Nile, Checkmate, and Invigor, and also Danube, Keynote 361 failed to show survival advance. This clinical trial, EV103, it's very interesting trial. The cohort, the combination of enfortumab, which is the antibody drug conjugate with pembrolizumab immunotherapy, versus enfortumab alone, and it showed a significant overall response rate, as you see here, around 64% overall response rate, and median duration of response not reached, and the progression-free survival median around not reached versus 8 in enfortumab single agent. Enfortumab vedotin for overall survival median 22.53 versus 21.7. At least we have a good combination for those patients ineligible for cisplatin to receive enfortumab pembrolizumab with a significant overall response rate. This is the enfortumab vedotin, which is a drug, as we said, is antibody drug conjugate. It's anti-nectin as the antibody, and also MMAE, the chemotherapy agent. Once it's bind to the urothelial cell, it internalize inside, and MMAE will cause disruption for microtubule. The approval of enfortumab based on this clinical trial as after failure of platinum and immunotherapy, the overall response rate for enfortumab vedotin as a single arm, single agent 40%. For those taxane, 18%, progression-free survival 5.5 versus 3.7, and overall survival 12.9 versus 9. Other antibody drug conjugate is sacituzumab govitecan, the same idea with the antibody, which is anti-TROP2, which is present around 83% of urothelial carcinoma. SN38 is the active compound. And it showed in this clinical trial after failure of platinum and immunotherapy, a significant overall response 27%, PFS 5.4, and overall survival 10.9. It has a high risk of high grade neutropenia, so we give a granulocyte colony stimulating factor after that. Phase 2 in this trophy U01, this patient after immunotherapy only, in those patients platinum ineligible, and sacituzumab showed the overall response 32% in intention to treat, and 53% for those patients naive to chemotherapy and enfortumab vedotin. Moving to castrate-resistant prostate cancer, we have two metastatic castrate sensitive update and the resistant update. For the sensitive, as we know, the previous recommendation is to give a doublet of chemotherapy, doublet treatment for those patients with high risk populations, shortly 6 cycle of docetaxel. Stampede, which is a clinical trial combination abiraterone with hormones, and showed survival advantage also. Stampede with one arm with docetaxel and also hormone showed a survival advantage. Titan ablutamide with the ABT and Archie's enzalutamide ABT. All of them showed survival advantage for those patients with metastatic castrate-sensitive prostate cancer. Nowadays, Aracine comes to the treatment option. It is a triplet treatment with darolutamide, docetaxel, and hormone ADT. This trial, Aracines, it is newly diagnosed metastatic for those patients with newly diagnosed metastatic hormone-sensitive prostate cancer, randomized patient to darolutamide and docetaxel versus docetaxel alone. And they stratified patient according to the volume, high volume, based on Charpy criteria and latitude, which presence of visceral metastasis or more than 4 bone metastases. It showed overall survival for those patients who received darolutamide more than placebo in high volume disease, but not low volume. But when they stratified patient according to the disease risk, the benefit was in both in high risk and low risk. Time to castrate resistant for high volume, the darolutamide showed a significant hazard ratio versus placebo, and low volume also has a benefit with additional of darolutamide to chemotherapy versus placebo. Also risk, also the time to castrate resistant based on the risk, the same to benefit in high risk and low risk. So nowadays we give Aracines with a combination darolutamide and docetaxel, and it is well tolerable with not more like no more side effect. So we start this new combination regimen. Now, other triplet treatment is PEACE clinical trial, which is abiraterone with chemotherapy, enzalutamide with docetaxel, and it should also survival outcome. But at the moment, we treat our patient as based Aracine clinical trial. For castrate-resistant prostate cancer, this is a PARP inhibitor update. As we know, the normal cell has 2 pathways for the DNA repair. For the cancer cell, they have only PARP pathway. So if we give PARP inhibitor, this will prevent the DNA repair for the tumor cells, and this lead to the cancer cell death. Propel, this is the combination of olaparib and abiraterone versus abiraterone. Those patients no prior treatment in metastatic castrate resistant. as a first line for the resistor setting, and it showed a final an update analysis, a median overall survival 42.1 versus 34 with p-value towards significant 0.05 with hazard ratio 0.8, and they stratified based on the HRR mutated, and it was significant for HRR mutated. But you can see here the screening for this study was all comer, okay, but then they stratified patient according to the genetic. Other trial magnitude, this is niraparib versus placebo, but as a first line for castrate resistant, they pre-screen patients, so they include only patients with HRR mutation, and it showed a survival advantage with radiological free survival, progression-free survival 19.5 versus 10.9 months with hazard ratio 0.5, significant p-value. Other TALAPRO 2 study, which talazoparib enzalutamide versus enzalutamide, and those in newly diagnosed metastatic castrate resistant prostate cancer, and all comer, they accept all, and then they stratify this with the mutation, and they found that all comer, they have improvement in radiological progression-free survival significant to the combination arm. This trial in metastatic castrate resistant Triton 3, but after failure of one line, which is hormone treatment, they randomized patient to rucaparib, which is Barabbaa inhibitor versus physician choice, either chemotherapy or other hormone, and showed significant survival benefit for rucaparib versus physician choice in radiological progression-free survival. And also, except for ATM, it did not show. So ATM, if you have a patient with ATM mutation, is not qualified for rucaparib treatment. Overall survival also showed a difference in 24 versus 20, but not significant p-value. So based on this trial, it supports the rucaparib in BRCA altered metastatic castrate resistant cancer. The last treatment, but not the least, the PSMA lutetium. PSMA antigen, it is a transmembrane that present in the prostate cancer. It's not expressed by normal cell except for salivary gland, kidney, and small intestine. Overexpressed correlated with advanced disease, and less expression in liver. That's why we have something that try to run lutetium, and we exclude liver metastasis because this less expressed. And we evaluate the patient before you give him lutetium by PET PSMA to see the intensity of the PSMA. And if he qualified, we give him lutetium PSMA every 8 weeks for 4 cycles, sometimes it's just 6. Lutetium, it is radioligand, it's targeted radioligand therapy against PSMA. It's radioactive that emit beta particles. It is different than radium, which emit alpha particle, resulting in prostate cancer death. The approval of lutetium comes through this single phase, through many trials, lutetium PSMA single arm that showed a significant decrease in PSA, more than 50%. In those patients with any line of treatment, 64%. This is Therapy clinical trial phase 2, comparing lutetium to cabazitaxel for those patients failed docetaxel hormone, and showed a significant PSA reduction, more than 50%, 66% compared to 37. Vision clinical trial. This is the phase 3 with lutetium versus standard of care, and showed a significant overall survival and progression-free survival. Thank you very much to allow me to participate in this medical conference. Please don't hesitate to contact me through this email, and have a wonderful day.
Thank you, Dr. Ismail Izzi, about his talk about the genitourinary updates. We have a comment here from one of audience on Dr. Ahmed. Dr. Fawaz. Dr. Fawaz has a comment.
Assalamu alaikum. You heard me?
Yes,
okay. Okay, can I start? I don't know. You heard me or no?
We hear you. نعم نسمعك. نعم.
Yeah. Okay. Okay, just thank you for good. I want to thank the organizing committee for this good conference and the excellent presentation from all the participants. Unmute, okay. Okay. I don't know. It is mute or unmute?
We can hear you.
Okay. Just I want to thank Prof. Ahmed Badi for this good organizing of this committee of this conference, and I have just small comments for his presentation. And as he said, maybe if, they will not need the surgeon. I disagree with him, and we have also precision surgery also in the surgery, also precision surgery like the precision oncology, and we still have the tumor board of both, and we introduce a lot of things in surgery to decrease the local recurrence and also to improve the resection of the small and occult tumors by this precision surgery, and we have before the pre-innovative surgery to resect the cancer cases or a high risk patient to resect them before their presentation of cancer. And so we have the artificial intelligence algorithm, and we have the mass sphincterectomy, and we have a lot of things to improve the in the precision of surgery for the cancer. And this is what I want to add, and thank you.
Really, we need you as a surgeon, but we don't need aggressive surgery. Thank you. Dr. Fawaz is the director of Fawaz Amran hospital, big hospital, modern hospital in Dammar. Really, he achieved, mashallah, tabarakallah, yani great, and he made great job in Dammar. And his hospital now is almost tertiary hospital in Dammar. Thank you, Dr. Fawaz, to be with us and for your achievement. We are proud of you.
Thank you. Thank you.
Okay, so because we are short of time, we'll move to the gynae oncology session, and because it is almost lunch. دكتور اوكي مين معنا؟ دكتور وهيب القباطي. هلا وسهلا. Dr. Waheeb will be speaker with us afternoon. Welcome, Dr. Waheeb. We cannot hear you, Dr. Waheeb. Okay, can you unmute yourself? We cannot hear you, doctor. We cannot hear you. Okay. Dr. Jam, you want to say something, Dr. Jam? Dr. Faid? Anybody want to talk? Just raise your hand. We are happy to see you. Dr. Faid?
السلام عليكم.
وعليكم السلام ورحمة الله.
شكرا دكتور احمد لتنظيم المؤتمر الجيد هذا.
Associate Professor of Pathology دكتور فايد اليوسفي.
وشكرا لاخواننا المصريين اللي جاوا من مصر، طبعا معظمهم دول كانوا زملاء يعني درسنا مع بعض and his colleague. بس ستيل انا اسال عده اسئله كده، اسئله صغيره يعني. دكتور احمد كنت قلت لنا انه ايه في امريكا تقريبا في الكولونيك كانسر اخذوا نيو ادجوفانت، ما احتاجوش لعمليات ولا اي حاجه اخرى والامور مشت زي الفل. طيب ليش ما نطبقش الكلام ده على الكانسر بريست؟ احيانا نيو ادجوفانت ثيرابي والكانسر يروح تماما، تيجي تعمل كشافه زي الفل، كلينيكالي زي الفل، بس بيعملوا لهم كده ماستكتومي. يعني ايش الفكره يعني حق الماستكتومي؟ ما هي نفس الفكره الان نيو ادجوفانت ما يحتاجش عمليات. هذه حاجه. الحاجه الثانيه لما نعمل اي ار وبي ار هرمونال ريسبتورز، من لحد الان انا مش فاهم يعني البي ار ريسبتور بوزيتيف اور نيجاتيف بيضيف ايش؟ هل في علاقات خاصه بالبروجستيرون بوزيتيف؟ يعني الحين يكون اي ار نيجاتيف بي ار بوزيتيف، طيب ايش هتدي له ايه؟ هل يعتبروا ذول هرمونال يعني ريسبونسيف ولا مش عارف لحد الان البي ار اهميته بالنسبه لكم ايش في العلاج؟
Okay, thank you. Any more questions? Yeah.
عمر بالفقيه.
Because this is
دكتور
from
سعد.
the previous session and it is pathological question. Anyhow, just simply the colon cancer is colorectal is completely different from breast cancer. Breast cancer is almost systemic disease, more systemic. Now, our approach for colorectal cancer, we can go to for conversion therapy even if the patient has lung metastasis, liver, lung, whenever we can go behind, and there is a limited role for the metastasiectomy, so we can go behind. This is the difference in the philosophy of the colorectal versus breast. While for breast cancer, when it starts to metastasize, this is the end of the story. There is no role for, we don't go behind the metastasis because system, usually there are micro metastases here and there. So this is the principle now, completely different. Colorectal, completely different from the breast. Breast, when metastasized, this is mostly the end of the story, despite of some data about the oligometastasis, which is till now controversial. This is the first part. The other question, this is important question by the pathologists always, they are, because we don't respect the progesterone receptors. Usually when it is estrogen negative and progesterone positive, we consider as, we deal with them as triple negative, because always pathologically we consider that the positivity of progesterone alone means this is technical artifact. And this happened the last week. I have one patient and the true cut biopsy, it came as progesterone 30% positive. I did mastectomy for the patient, upfront surgery, lumpectomy. At that time, the final pathology became triple negative. So really, we don't consider progesterone positivity as true positivity. If it is if come alone, we consider it as artifact. And this is the usual scenario. We end up in the surgical pathology that it is negative almost. Dr. Jam, you want to say something? دكتور أصحاب الجايني دخلوا الآن. دكتور وليد. دكتور وهيب القباطي الصوت مظبوط معك؟ Again we cannot hear you. دكتور فايد تبغى تقول حاجة؟ تفضل.
عمر بالفقيه. How to manage يعني هو يعني الكارسينويد اوف ستومك مايكروسكوبيك كارسينويد اوف ستومك، يعني واحده 60 سنه دخلوها بالمنظار مالتيبل بوليبس سمول نص سنتي، وبعد كده اخذوا بايوبسي منها طلعت مايكروسكوبيك كارسينويد. How to manage such a case?
This is surgical disease. When you resect, this is the end of the story. Yani, we know we have the stratification or classification based on the mitotic rate and the size, the three parameters. In your scenario, most of the case will end up as low risk, so just surgery, and this is the end of the story. So resection and خلاص اوكي. طيب دكتور عمر مش موجود صح؟ انا عندي سؤال له بس مش موجود. المرضى منتظرينه في العياده، الله يعينهم. اتفضل ابو حالة emergency. طيب we'll move now to gynae oncology session, so we'll invite the moderators. اوكي. الوهيب بيدخل معنا ما عنده مشكله. from صنعاء. دكتور سلطان النابي from صنعاء. دكتور فضل النجري from صنعاء. Dr. Mahran Abdo from Saudi, Dr. Najib Al-Dubai from Saudi Arabia. We have Dr. Radfan Naji from Saudi Arabia. We have Dr. Khalil Al-Alimi from Sana'a. We have Dr. Nisreen Haidara from Aden, from Saudi Arabia. Dr. Hisham Abdulaziz from Taz. Dr. Yahya Mujalli from Sana'a, and Dr. Lutf Al-Mikhlafi from Sana'a. You can start, Dr.
Bismillah ar-Rahman ar-Rahim. I have the pleasure to introduce Dr. Waheeb As-Salawi from Saudi Arabia. He's a consultant, medical oncology, King Fahd Specialist Hospital, Dammam, Fellowship Program Director, Adult Medical Oncology, King Fahd Specialist Hospital, Dammam, oncology cancer in the same hospital from Saudi Arabia. In the gynecology oncology session, and he will be presented how to decrease the recurrence of ovarian cancer.
Thank you. First of all, I have to thank you all the organizing committee, scientific committee, Dr. Ahmed Bahashwan and Dr. Waheeb, to invite us to share in this meeting. And that's really, I'm proud, and I have to congratulate all of you for a great meeting. And that is really is my pleasure to see all of my dear friends here in the meetings. Thank you, Ahmed, and thank you for all organizing and chairpersons, and also for moderators. I can share my slides, Ahmed. Dr. Huda, I can share my slides. Yes.
Okay, start.
Thank you. I really, again, I'm proud about the meeting. Congratulations for the all, and to see the from different parts, the people in the oncology. I'm assigned to talk about maintenance therapy in current practice in ovarian cancer. As you know, in very brief things, that epidemiology of ovarian cancer, it is the one of the most common cause of cancer in gynecology, and about the risk of patients that developed metastases is very high, and that is globally about 6.6 per 100,000 patients per year was diagnosed. That's according to the data base from US. And the subtypes of ovarian cancer, the most things we are concerned about all the time, the most common is the type 2, what you call the serous carcinoma of the ovaries. And this is the genomic disorders of high-grade ovarian cancer, and looking for a different type and mutations found in the patients is anything can be helped in detections and select our treat of patients. This is the just seeing the cartoon of how is biomarkers looking for our ovarian cancer can be targeted therapy and looking for improvement in the treatment, especially the maintenance therapy. This is showing about 50% of patients diagnosed with ovarian cancer have genetic mutations. Is that germline or as HRD testing? And briefly, I mentioned that what's meaning of the HRD testing. All the BRCA, what you call BRCA testing, the concept of the germline mutations or non-germline mutations, and then sporadic type leading to the what you call also now the mutations of the homologous recombinant pathway and leading to the HRD deficiency. Then come to the mutations that's improving, seeing that from the 10% to 27% in mutated BRCA mutations in PRCA2 and around 40% to 46% in patients with BRCA1 mutations. This is only just mentions for to review those patients. There is two types of germline. There is a germline mutations that's coming from the germline mutations, and we are looking now for a somatic mutation from the tissue. That is, the tissue can be how is looking those patients with tissue to looking for a mutation that is found. And that's increasing from 15% in the germline to 35% in tumors, and then reach to 50% in the HRD testing. Just how is that curve showing of, this is the cartoon showing up of the germline from the 13% in the germline mutation to the 50% in the HRD testing. When we should be test the germline or the BRCA test or HRD, all the now recommendation from the NCCN guidelines, ASCO and ISMO, all is recommendation to do genetic testing for our patients. And as you know, only the chemotherapy is helping for our patient after surgery for sure. That is depend on the fitness of the patients, histological type, burden of the disease, and also if we give the neoadjuvant, and then the impressment on the guidelines. As most of who is treating the gynae oncology or the gynae cases from the surgical point or medical oncology point, around 40% of the patient only have 5-year survival. And this always we are looking for the anything to improve the patients and decrease the relapse rate. As you know, most of the patients have a recurrence in the first line that can be considered as after 12 months. Sometimes it's early, what you call the platinum resistance or platinum refractory. At that time, those patients needing some sorts of the adjuvant or what you call the maintenance therapy. This is only just showing that how is improved in the ovarian cancer journey to start from 2030, from 23rd of the chemotherapy, only the platinum-based chemotherapy, then till 2011, when we are start to shift paradigm by adding only bevacizumab to the chemotherapy with only improve of progression-free survival, no overall survival. Then in 2018, start PARP inhibitors that as a recommendations of the NCCN guidelines and ISMO to add PARP inhibitors to our patients as a metastatic in the metastatic setting, then move to the adjuvant setting. Now we have a lot of those molecules, PARP inhibitors in the adjuvant setting. This is just seeing how is the improvement in the PARP inhibitors of ovarian cancer reached to the 2023 regarding the PARP inhibitors as the adjuvant setting. As a maintenance therapy, this is the going around 240 PARP inhibitors clinical trials to reach 2020, and those all is evidenced by the FDA to start the maintenance therapy for our patients. And as you know, that is the PARP inhibitors is caused the specific cell death, looking for the normal cells, and that cancer cells looking for the some sort of cell death, looking for how to block of the cell survival by adding DNA damage. And that's what can be happen in the DNA repair by using the PARP inhibitors. This is the just showing we are not doing go in details regarding the HRD testing, but we have what called HRD myriad testing to looking for BRCA and HRD positive or negative. Then there is that scoring looking for myriad. This is that HRD negative or positive by the 40 or 45 definition of that adding for our patients. As we know that aggressive clinical surgery and adjuvant therapy, but still with all of this, there is about 40 of patients have a relapse rate, around 40 only survival, and 70% of patients have relapse. This is the guidelines showing all of these guidelines. The all in the maintenance therapy is recommendation of the PARP inhibitors. And that how is impacting of the doing the test or not doing the test nowadays. Two recommendation, every patient he need to start on PARP inhibitors. This is only just for overall survival benefit, 7 years for patient on the solo one adjuvant therapy after patient receiving the neoadjuvant or adjuvant, then surgery, CR or PR, and then going to receive the maintenance therapy. And those patients' characteristics, we are not go in details, but this showing that overall survival benefit is not rich, and that is patients showing that very clearly separated at 3 years and even at now is 7 years, is still very significant value of adding olaparib. Also at progression-free survival, showing in the first line setting, and even for subsequent second line therapy or death, very significant adding PARP inhibitors to our patients. What is the side effect? Most of those side effects is only nausea, vomiting, especially in the first cycle. We have to look carefully for our patients, seeing him every 2 weeks and then every month in the maintenance strategy. Then came to that, not only that, added bevacizumab to the first line, setting Paula-1, adding to the PARP inhibitors in some selected patients, especially patients with HRD positive. Those patients, PARP inhibitors, bevacizumab versus bevacizumab alone, showing also again very significant those patients with 5-year survival, around 41 with significant p-value. Again, for HRD positive, very significant value with a median overall survival 75 compared with 57 months, and with very significant those patients have combination of both, especially with HRD positive patients. Those for Paula-1 with HRD positive group, sub-selected group for those patients with very significant value with almost median progression-free survival 46 compared with 17 months. With all different dose PARP inhibitors, even for HRD positive disease, BRCA positive disease, and HRD negative disease, showing there is a significant value of adding olaparib with bevacizumab more for patients with BRCA and HRD positive disease. Then there came the PRIME study, adding niraparib regardless of the status of the patients and looking for PFS and then overall survival. Again, seeing that about 57% reduction in risk of relapse or death in HRD positive patients. If you go to the all populations, again, around 38 to 40% have a reduction in risk of relapse in ovarian cancer patient in overall population, meaning that even patient there is no HRD positive or BRCA positive, still there is a significant of added PARP inhibitors in maintenance therapy. And this is clear recommendation to add in the PRIME study for all patients who have ovarian cancer advanced after partial response or complete response, to add to them the PARP inhibitors as maintenance therapy. For those patients with HRD positive patients at 4 years, seeing very significant value with about 40% or 38 compared with 17% who didn't receive PARP inhibitors. For those also, again, patient with 13.5 months compared with 8 only months for secondary progression-free survival. This of compared for patient HRD positive and HRD positive with BRCA wild type, again, seeing very significant positive value with 55 reduction in risk of relapse or death. And here also for HRD positive wild type BRCA is 35 reduction of relapse. And this is to confirm again, niraparib in the PRIME study, again, translate the same message for patients with BRCA status to add the PARP inhibitors, again, with HRD group or with all patients. If we compare those, we didn't compare trial to trial, but just showing for us that solo one with PARP inhibitors with olaparib, PRIME with niraparib, again, very significant progression-free survival value. And again, Paula, if you see all those, seeing the very significant progression-free survival to add of those patients. Not only that, there is also another molecule, and this is the Athena mono trial with using rucaparib and translate the same message of adding PARP inhibitors. That's showing that 38 compared with 11, almost doubling progression-free survival for those patients with receiving rucaparib in the adjuvant setting. And not only that, even for the intention to treatment of those patients. And when we go for a details of HRD positive patient, seeing all the subgroup is benefit from rucaparib. And based on that, rucaparib is approved as a maintenance regardless of the molecular status. And this is showing that olaparib and bevacizumab and niraparib, the group of all of the class effect might be caused fatigue and GI symptoms and bone marrow, sometimes leading to the anemia and thrombocytopenia, and with bevacizumab can be caused hypertension. This is the most toxicity with a class effect, hematological toxicity and fatigue or asthenia and gastroenterology. For that, when we are prescribed this our patients the PARP inhibitors in the first cycles, we should be seeing patient every 2 weeks and then moving to the every month based on those treatment protocol. This is the compare of those all in the first line. We have solo one confirmed the same mainly for patients with BRCA and HRD positive. Paula one mainly for those patients with HRD positive combined olaparib with bevacizumab, prime for all patient categories regardless of the HRD status and HRD or BRCA mutations, and also bevacizumab based on GOG 218. As we know, that is the influence about how to be select those patients, looking for genomic biomarkers if we can have facilities to do it. But now we have, sure enough, we have evidence to use these molecules regardless of BRCA and HRD testing, influence of the timing and outcome of surgery, response to the chemotherapy in the first line, and quality of life. This is the strategy of platinum-sensitive disease in ovarian cancer. Platinum doublet chemotherapy is still the adjuvant standard of care. Then a maintenance strategy to use if this patient have BR or CR can be used. PARP inhibitors as a maintenance. If HRD positive, we can be used bevacizumab with PARP inhibitors, or if there is not HRD, we can just maintain of bevacizumab therapy. This is the approval of the those molecule in Europe and in United States, and for all comers can be using olaparib or niraparib and now rucaparib. Again, this is the all drugs is already approved in the first line setting. This is our strategy, and to use that is this patient. This is very important slides. Just when we are discussing in our tumor board with a gynae surgeon or oncology surgeon, looking for is this patient is for debulkable to go for upfront surgery, or can be neoadjuvant for some selected patients, then adjuvant therapy. If this he did surgery and we can use bevacizumab mostly in the adjuvant setting, then no bevacizumab, we can go for solo one or prime based on the PARP inhibitors using the HRD if available, or going directly to use niraparib or olaparib. If patient receiving bevacizumab, can be go to the bevacizumab maintenance, or adding if HRD positive based on Paula one using the PARP with bevacizumab. Other than that, if this is not available, can be used according to the GOG 218 bevacizumab maintenance therapy. Again, NCCN guidelines is translate the same message. All of this is recommendation using niraparib, rucaparib, olaparib in the maintenance strategy after patient is doing surgery, adjuvant therapy, then a maintenance strategy. I think this is very important to improve the progression-free survival and overall survival. This is the last slides for me, just for a conclusion from our talk. The PARP inhibitors reshaped the treatment landscape in ovarian cancer. Every single ovarian cancer patient, if we can do, should be tested for BRCA or HRD status. And then if we can do somatic or germline or HRD status, this is the good best predictors to the response. But if it's not available, we can start giving the PARP inhibitors as a maintenance therapy. Also, both germline can be up to 50% in our patients. Not only that, this is the maintenance therapy and can be helping in the recurrence disease based on the study 19, Solo 2, and also Solo 3, Nova and Aerial 3, and can be used even in the maintenance therapy regardless of the molecular status of the patients. Thank you.
Thank you, Dr. Walid, for your nice information. Next speaker, Dr. Fawzi, about the update of radiotherapy in gynae oncology.
Dr. Fawzi Abu Hajla, consultant radiation oncologist in at King Al-Hussein Cancer Center, and he was hold Canadian relationship and radiation. Welcome with you in our conference. Dr. Fawzi? Dr. Fawzi, are you with us?
Bismillah ar-Rahman ar-Rahim. At the beginning, I would like to thank Ahmed Abadi for this kind invitation and his colleague. This is a very well organized conference. So my talk will be about radiation therapy updates in gynae oncology. I am Dr. Fawzi Abu Hajla, a radiation oncologist at King Hussein Cancer Center. So at the beginning, please let me start with, I have no disclosures. The topic I'm going to discuss today are some recent updates in the practice in regards to radiation therapy and its use in gynecological malignancies, the advances in radiation therapy planning, the role in adaptive radiotherapy in gynecological malignancies, development and evolution of brachytherapy over the past decades, and possible alternatives in limited resources settings. From the beginning, starting with the update, we know that last week there has been a new update regarding cervical cancer management. This update came from the European Society of Gynecological Oncology in collaboration with the European School of Radiation Oncology and Pathology Society as well. Also, I'm going to discuss regarding the use of new novel agents, mainly immunotherapy, jointly with or combined with radiation therapy, the impact on pathological specimen specification in regards and the decision management regarding use of radiotherapy in adjuvant settings for uterine cancer, and the change in radiotherapy fractionation and dose regimen for uterine cancer and cervical cancer as well. So at the beginning, as I said, last week, there has been a new guidelines. It was published in the International Journal of Gynecological Cancer. In regards, I'm only going to discuss the radiation therapy part. So in regards to radiotherapy, frankly, there has been no major change. We know that definitive radiotherapy is still the standard of care for locally advanced cervical cancer. It's still preferable to use the intensity modulated radiotherapy and image guided radiotherapy. They are preferred specifically for nodal involvement. That's where we can deliver a simultaneous integrated boost instead of sequential boost. This would result in shorter overall time. And as we know from previous studies and literature, every week extended in the duration of treatment in definitive chemoradiotherapy will lose around 5% in local control for cervical cancer. So using IMRT would result actually in delivery in shorter time, helping to improve the local control. However, they also stated this in their guidelines. If intensity modulated radiotherapy and image guided brachytherapy are not available, we still should use what we have. So 3D conformal radiotherapy with cisplatin can be delivered, and the dose can be delivered for involved nodes in a sequential fashion. And in regards to brachytherapy, still 2D or let's say X-ray based is an option if we don't have the MR or CT guided brachytherapy. One more advancement that we have seen in the past couple of years in regards to the management of adjuvant radiotherapy and cervical cancer. We know the STARS, which is an Asian trial that discussed the use of radiotherapy, chemoradiotherapy in concurrent fashion or sequential fashion for cervical cancer. So what they did, Ji Hong and his colleagues, they addressed around 1,000 patients. They looked into stage 1B to 2A patients in cervical cancer who underwent radical hysterectomy and trying to find the optimum adjuvant management. And looking at their data, they showed that sequential chemoradiotherapy resulted in better overall disease-free survival. However, the chemotherapy that was used in the sequential regimen, it included paclitaxel as well to platinum-based. And this is one of the rationale for their findings, that they use more intensified systemic therapy, in addition that they introduced the chemotherapy even earlier than the chemo which was used in the chemoradiotherapy arm. So in their study, actually, they showed that there are some improvement in disease-free survival and overall survival to use a sequential. And frankly, it was not pure sequential. It's more like a sandwich protocol, because they used 2 chemocycles prior to radiotherapy and 2 chemocycles after radiotherapy. However, it showed a significant difference, and it might be used as the standard of care for patients who has a high risk or a high risk features in pathological specimen and after following hysterectomy for cervical cancer. So to summarize what we have seen in the past couple of years in regards to cervical cancer, we know that for locally advanced definitive chemoradiotherapy is still the standard of care. However, for stage 1B to 2A larger tumors might be treated with definitive chemotherapy as well, to avoid having surgery with incomplete resection. Observation is a safe option for low risk early stage cervical cancer. So if we have patients who would undergo a radical surgery with low histological features, observation might be an option. Adjuvant radiation can be considered an intermediate risk stage. The addition of chemo is still recommended for high risk group. And for selected patients in intermediate risk group, we know that from Peters et al. And prior publications as well, sequential chemotherapy has favorable outcome when compared to concurrent chemotherapy. This can be replicated with further studies to ensure the use of this data. So what else we have in recent literature? We know, as I stated before, that there has been a more the fashion today is to use immunotherapy and some novel new agents. We know that these agents can be work in 3 main categories, as you can see on the left side of the slide. And I'm sure there is many medical oncologists seeing this lecture, and probably they understand these topics more than I do. But what I know in regards to radiotherapy and the use of immunotherapy or combined agents, that there is some synergistic effect between radiation and immunotherapy. However, we still don't know the optimum immunotherapy combination with the radiotherapy. As you already saw on the table, there are many ongoing trials trying to address these questions. We also don't know the sequencing of therapy, whether should we start with immunotherapy or should we combine the treatment. There has been some phase 1, phase 2 trials showing the safety profiles for combining the treatment of these novel agents with radiation. And also there are some concern regarding the additive toxicity for large tumor fields that we use with radiotherapy, especially for extended field with cervical cancer, whether there is a large volume of organs that being irradiated, and whether this is safe to be given jointly with immunotherapy. A very good example regarding the use of immunotherapy, we know the Keynote 826 study, they addressed the use of pembrolizumab or anti-PD-1 jointly with radiation for cervical cancer. However, they include patients with persistent, recurrent, or metastatic cervical cancer, and they showed there is a significant improvement, and there's an excellent oncological outcome when compared to placebo for these patients. So moving forward, now we are talking about the pathological specimen and the selection for the use of adjuvant radiotherapy in endometrial cancer. We know that it has been already stated that lymphovascular involvement in the total abdominal hysterectomy specimen would impact the local control and overall survival, and that's why we recommend adjuvant radiotherapy. However, for early stage, there has been no clear cut for the definition of lymphovascular invasion, whether a focal or extensive or substantial. In the PORTIC-2 trial, when they compared with the external beam radiation versus brachytherapy, only 20% in their group included LVI and was not classified whether focal or substantial. And that's why we still have this dilemma during the MDT for gynecological malignancies. If a patient has early stage with LVI, should we go with adjuvant brachy alone or provide adjuvant external beam as well? And in this study, they actually tried to address the cutoff, and they found that if there is 4 or more lymphovascular involvement in vessels, at least in one slide, it should be defined as extensive LVI. And in this publication, it provided a clear cutoff for pathologists to define extensive LVI versus focal LVI, and this will help in the management. So what we do now, if the patient has extensive LVI with early stage, I will still recommend external beam instead of brachytherapy for these patients. Another recent advances and change in practice in regards to adjuvant radiation in uterine cancer is this particle study. This study was published last year in the JAMA Oncology journal, and they found that there is a safety profile. However, this publication is unique. They only used 30 grays instead of 45 and given over 5 fractions. The main idea of their study is to provide adjuvant radiation for endometrial cancer within 5 days instead of 5 weeks. So this is a replication from previous studies in other tumor sites. That's where we use hypofractionation, providing higher dose and less treatment time. And they found there is a good safety profile, and radiation can be delivered actually in a 5 weeks fashion. In a 5 days fashion instead of 5 weeks. However, we're still awaiting for the longer follow-up period to use this regimen as a standard of care. For the time being, we are still using the 5 weeks, but however, I think we're gonna shift for the 5 days regimen in the near future. So how this improvement was done, you can see in this slide. You can see there has been a shift in the treatment planning over the past decades. Looking at this study by Himmel in the critical reviews in oncology, showing the clear definition. I'm going to try to use my marker. Hopefully it's going to work. So you can see in 2-dimensional planning, there is a large area that we should not irradiate, or we do not need to radiate, is being exposed to high dose of radiation. This was changed a little bit with the use of 3D planning. You can see there are some sort of sparing. However, the red area is large, showing there is still a significant area of normal tissue being irradiated. And the use of inverse planning, you can see the sparing where there is no color here on the sides and the bottom and the back. There we can spare much area. You can see on the sagittal cut, the bladder is spared of radiation. However, in the 2D and 3D, there's a large volume of bladder being irradiated. And this has been shown in several studies, showing that inverse planning in radiotherapy has resulted, it didn't show improvement local control. However, because we are delivering the same dose basically, but it improved the toxicity. So less toxicity profile in regards to GI and GU for patients who are being irradiated for adjuvant treatment in gynecological cancer. And this whole thing started in the early 19th, where radiotherapy was being used for treatment of gynecological malignancies. And then after that, there has been a rapid improvement using two-dimensional planning, 3D or three-dimensional planning. That's where we have a 3D image and we can import our target and define the areas that we need to irradiate. Afterwards, we have the inverse planning. That's where we can shape, we have more ability to shape radiation within the body. And in early years, in recent years, there has been the use of the new development of adaptive radiotherapy that I'm going to discuss in the coming slides. So as you can see, this is the timeline showing the major improvements that happened to radiotherapy in general, starting from 2-dimension, 3-dimension, and then shifted towards the IMRT, VMAT, and going forward, now we have the online MR LINAC that's going to be used for adaptive radiotherapy, and finally the ion beam or the proton beam radiotherapy. And what we do at KCC now, we are having the installation for our MR LINAC machines as we're going to start treating patients in the next couple of months, hopefully. So what is adaptive radiotherapy? I'm just going to show you, that's where we have an image. We adapt the plan. That's we see if there's any major shift. For example, we know the cervical cancer, uterine cancer, the location of the areas that we need to treat is being held in between the bladder and the rectum. So it can, the volume that we need to irradiate and the position of the irradiated area is being shifted mainly on day-to-day basis due to distension, filling of the bladder, filling of the rectum might change the position of the irradiated area. So long story short, looking at adaptive radiotherapy, you can see this is what we do normally in 2-dimension or 3-dimension. We have to, in order to irradiate the tumor, we also irradiate a large area of normal tissue surrounding the tumor to ensure that we are not missing the target. However, this has changed, and now we only irradiate a very minimal volume of normal structure surrounding the tumor. But we have the capacity to ensure that we are irradiating the disease because we are using the online adaptive radiotherapy. Our experience at KCC, we also published our data in regards to use of adaptive radiation in gynecological malignancies, mainly for vulvar cancer. This example, you can see that there's, for definitive chemoradiation for vulvar cancer, there has been a major or a great response during the treatment. That's where we can recalculate the doses to minimize the areas that we need to radiate. Our publication has shown that the tumor volume is the only factor in univariate and the multivariate analysis that impacts the need for further planning and resimulation. Switching gears now for another topic that has a major role in gynecological radiotherapy is the brachytherapy or the internal radiation. The story started when we used to use the C-arm for X-ray images. So in the early years, we used to make anterior, posterior, and lateral images where we put the ovoids, and you can see the intrauterine tandem within the uterine cavity. We calculate the dose and deliver the treatment. However, we did not visualize any of the target because this is simple X-ray, so we would not really see what's going on inside. However, when we did now recently, we can use the CT scan. You can see now we can visualize the organs at rest. We can see the bladder, we can see the rectum, and we can see that our target, the cervix, the parametrium, and we can calculate the dose more accurately. However, as you see, we only have one channel inside the uterine cavity and also for the ring or the ovoids. So we are still limited in delivering the dose options. We can see better, we can know where the dose is going, but we do not really have much options in controlling this dose. And that's where we have more advanced level. That's the standard of care. I think Hussein Cancer Center is the MR interstitial brachytherapy. That's where we not only using the central tandem within the uterine cavity, but also we can use, as you can see here on this axial cuts that we inserted because of this hyperdense residual mass after concurrent chemoradiation. We can see still there is residual disease, and in order to deliver higher dose of this disease, we implant interstitial needles within the disease, and you can see here on the coronal that we can shift the dose into the lateral edge of the tumor, residual tumor, without irradiating extra volume of unwanted tissue that we do not wish to irradiate. So looking at this data from Han et al., which was published around 10 years ago, showing after the development of VMAT and IMRT, whether it can replace brachytherapy for cervical cancer, and the answer was not. Brachytherapy is still a superior option in regards to cause-specific survival and overall survival for patients with cervical cancer. And also another attempt was done to address if SBRT is better than brachytherapy for cervical cancer. And also in this study, brachytherapy versus SBRT showed failure of SBRT to replace brachytherapy. So we know in cervical cancer, definitive chemoradiation for locally advanced is the standard of care and should be followed by intracavitary brachytherapy. However, there has been major improvement in brachytherapy in regards to image guidance and the use of interstitial needles. So after discussing and mentioning the SBRT, let me just tell you briefly about the role of SBRT in gynecological malignancies. I'm sure many of you have already known the benefits of SBRT in regards to oligometastasis or oligorecurrence in other sites and other tumors. It has been shown that in the COMET-SABR trial that to irradiate the oligometastatic disease has shown to improve for all survival, but these studies did not include gynecological tumors in their cohorts. They mainly discuss other solid tumors, mainly as GI, breast, lung, and prostate. However, for gynecological malignancies, there has been many studies trying to address. Already I showed you that SBRT is not a replacement for brachytherapy in treating the primary disease. However, what about the metastatic disease? So actually there has been many trials, as you can see here, but we know that the role of SBRT in gynecological malignancy is not clear yet. However, what we do, and it's a common practice now, is waiting for the ongoing trials to show. There have been many retrospective trials showed there is improvement in regards to local control for these patients. So if a patient who has if we have a patient with young age and oligometastasis, I would still recommend to treat with SBRT for these patients. Finally, I'm just going to go briefly about this topic with what should we do in limited resources settings. We have faced this issue in different places. We know that radiation remains a primary treatment modalities for gynecological malignancies. The more modern machines that we have, it will help us, give us the ability to shape radiation, deliver higher dose, using less fractions, sparing organs at rest. But what should we do if we do not have all these fancy tools? So there has been many recommendations about this. There has been many publications trying to decrease the gap between high and low middle income countries. There has been some proposals for brachytherapy, for example. There has been many ongoing trials, and some retrospective data showed that ultrasound might be enough instead of using MR and interstitial needles. It can provide a durable local control. And if brachytherapy is not an option anyway, because of the limited restrictions over import of the iridium source, for example, that's where we would recommend to provide an external boost instead of using brachy. We know it might be less, it might provide less local control. However, it can be better than not doing anything for these patients. It might still provide a durable control for the tumor. And in this slide, it looks by Dr. Omesh, they showed some proposal for the limited radiotherapy availability in low and middle income countries, and what are the steps that should be performed. Adding to these steps regarding the government, the education, development in multidisciplinary, most of these options needs resources, but still we can work on at least in-house or hospital-based multidisciplinary experts recommendations, trying to provide guidelines. Using of hypofractionated regimens would make it an option because you can treat more patients, so we can accommodate more patients every day and help in reducing long waiting list if this is an issue for the radiation oncology department. Adding to these options, as I said earlier, you can also use ultrasound for image guidance regarding brachytherapy for cervical cancer. So in conclusion, radiation oncology is a critical specialty in the multimodality treatment of gynecological malignancies. It should be implemented under the umbrella of national or international guidelines. Detailed histopathological assessment to address the risk feature is crucial for decision making. Personalized selection of the modality is would result in the optimum outcomes, and special consideration should be taken to mitigate the long waiting list and limited technologies and limited resources to things. Thank you very much, and would like to thank Dr. Ahmed Abadib again for this kind invitation, and thank you very much.
Thank you very much, Dr. Fawzi Abu Hagla, for a very nice presentation. Now we will start the discussion. Okay.
Hello, Dr. Waheeb. You are mentioned in your presentation about the trial applied for the patient's management from ovarian cancer. You use double blindness. How to follow, if you use double blindness, how to follow these patients? This is the first question. The second question about the survival rate. What are the survival rate minimum and maximum for your patient in your trial?
Thank you. Thank you for great questions. The first questions, we know those who are the one of the most difficult to follow the patients who in the adjuvant setting. But for ovarian cancer, you know, those patients we have to follow as a double blind, those patients have adjuvant therapy, then he has in CR or PR, we have to document as there is no progression of disease after the chemotherapy, then giving the adjuvant strategy. As you know, those patients we can follow up like any other patients. We do a CT CAP every 4 months to 6 months, and with clinical examination and CA125. For a follow-up of those patients, that is like other patients. The most important also to maintain therapy for almost as per guidelines and per study for 24 months, meaning 2 years of therapy. This is the first one. For a second questions regarding, I'm sorry.
About the survival rate.
Yeah, the survival rate, all the study is mentioned, most of those for progression-free survival. There is even now overall progression-free survival of almost 7 years. If you compare both the placebo arm and olaparib or niraparib, or also rucaparib, all of those show very significant progression-free survival, intention to treatment, and relapse rate. But all of those is going on the immature for the overall survival data. especially for the new generation, the Rucaparib and Olaparib. But the trend of all of those very significantly, if you see that almost 53% of those patients still have a life after the 7 years, meaning that not only that, hazard ratio for those patients is only 0.2. We didn't see that in the clinical trials. For almost 80% of patients have prevented from the relapse and death.
I have question, and comment. Just now we are planning to, tailor-made the medication list for our country regarding, the main drug which use it to prevent the recurrence of ovarian cancer. We are talking now about Olaparib. So what is the message you want to deliver to the policymaker about the importance of adoption or inclusion of the Olaparib in our drug formulary for ovarian cancer cases?
Thank you, Dr. Ahmed. Thank you, Dr. Ahmed. I think that's very important message from us. And as Dr. Ahmed Badib has mentioned, Prof. Ahmed, I think now we have very comfortable, we have very strong evidence to look for those patients, ovarian cancer patients, who has disease stable or not progress after adjuvant therapy to receive the PARP inhibitors. There is very strong evidence in this regard, not only for BRCA positive and HRD positive, even for those patients, all populations, we see in the clinical trials also about 38 to 40% have very significant survival of and progression-free survival. I think the message we have should be for all patients and fair for our patients now in 2023, just treat those patients with chemotherapy alone, and there is no maintenance strategy. I think very important to add in for our patients the maintenance strategy with PARP inhibitors. What we all have this evidence now for drugs is FDA approval to add PARP inhibitors to our patient as a maintenance strategy for 2 years of therapy.
Dr. Waheeb, I have one question about the BRCA test. You advise that all female to do a BRCA test and at any age, and if the patient have BRCA test positive, how we deal with this patient in this case?
Yeah. Thank you, Doctora. That is again one of the practical questions, and even here in Saudi Arabia, we face to start even when we start to looking and practice those. Now almost now 6 years treat the patients with PARP inhibitors, but for patients now, if he has BRCA become positive, is this BRCA is a tissue or a germline? I mean, if is a tissue, those patients should be go for a BRCA germline mutations. If SCAM is positive, should be go for the strategy of BRCA positive patients. If it's only the tissue, again, HRD is positive, that's it. And usually we are not recommend now for every patient to do germline mutations unless for those patients have strong family history or patient have a positive BRCA by the tissue, then we recommend to do germline mutations. If germline came positive, then we'll go for the genetic counselor to look for the whole family in regard of the risk reduction strategy for her and for her family.
شكرا. Thank you very much. سؤالنا للدكتور فوزي أبو حقلة. Dr. Fawzi, you said that in this lecture about the use of the immunotherapy with the combination with radiotherapy. In a case of cervical cancer, if it's cervical cancer degree 1, 4 centimeter lesion, can this success in the treatment eradication of the problem? Because if this without surgical intervention can be safe also the uterus and the ovaries.
Just Dr. Fawzi is not here. Who simply just chemoradiotherapy is still the standard. for locally advanced cervical cancer. Now adding immunotherapy. So still the chemotherapy, chemoradiotherapy is the standard approach for locally advanced cervical cancer. So we have to respect the guidelines for localized cervical cancer, the standard of care. The option, the mainstay is surgery, locally advanced chemoradiotherapy, and now while the addition of immunotherapy, it is still, I mean, investigation and not included in the standard of care. Dr. Fahid, you want to say something? Because you are short of time. It's almost lunchtime. Dr. Fahid, yes. Your voice.
ايش اسمه بس في 35 female with unilateral ovarian tumor. Histopathological diagnosis was borderline serous tumor. How to manage such a case?
Surgery.
Follow up or resurgery or
It
what?
is surgery only. Borderline ovarian cancer surgery only. Thank you.
Thank you very much. شكرا جزيلا للحاضرين. الآن اللي هي time for the lunch break.
Thank you so much.
شكرا جزيلا.
Thank you.